Hi, it's Sunday morning. Andy and Alan here from Return to Healing, and we're going to talk about some healthcare issues that are both timely because of articles that just came out, and also just things that we should talk about. And one of the big things. One day we'll talk about how Alan, how we both got through COVID. It was a long time ago, but it was very impactful for both of us. But um, but
Me,
just the idea uh, of vaccines being politicized in the recent past, and this was big during COVID. You were either a pro-vaxxer or anti-vaxxer. There was a binary where there was just one right answer, and we got to the point where it just became if you criticized even a single vaccine or the idea of getting multiple vaccines all at once, you got put in that bad camp. And so, it's sometimes you have to put some science and common sense into the conversation, which is very difficult when something's politicized.
yeah.
But what's your
Well,
take on all this?
well, I don't even think we've overly discussed this too much, but it brings up one thing. We should definitely do an episode on COVID. So good morning, everybody, and our experiences, because it was the worst couple of years of my life, and our country's response. We'll talk about it separately because if we get started, we'll never get to the topic. But the topic came up because I got a New England Journal article on the uselessness of Paxlovid. And then I've been bombarded with patients asking questions. Part of it is the TV commercials with the pneumonia vaccine and the shingles vaccine and stuff of people coming in and asking for vaccines. And I just want to start by saying, I'm a family doc, so I treat kids too. I am not an anti-vaxxer. In fact, I vaccinate all of my children in my practice for all the recommended vaccines. And in adults, like I don't tell someone like you're crazy if you want a pneumococcal vaccine. I just ask them why they want a pneumococcal vaccine and did they really look at the evidence for some of this stuff? So, we're going to dig into that a little bit today. And again, I kind of tell people these things are your choice, what you want to do. And you need to make the decisions of what you want to do. But go ahead, Andy.
Yeah, I mean, and that's the whole point is it is there is should be some choice here. That's been a lot of the debate is whether we should give people choice because obviously during COVID we did not have there was no choice. Um, and there are other issues, there are other circumstances where choice becomes if your doctor calls you an idiot for not getting it or for getting it, that puts you in a bad position. But talk about the pneumococcal vaccine. That's a vaccine against people call it the pneumonia shot, but it's not a pneumonia shot. It's for a particular bacteria called pneumococcal.
One kind of pneumonia.
One kind of pneumonia or whatever, sinusitis. It just causes some stuff. But the thing is that there's an old vaccine, the pneumococcus vaccine that's been out for 50, 60, 70 years. And the big studies on it show that maybe one out of 1,000 people will prevent a serious complication from that vaccine. Most people who get it have the same chance of getting pneumonia as people don't. And then they started coming up with new vaccine, new pneumonia, pneumococcal vaccine, same to the same organism, by the way. And you have to get both. So they did one study, Alan, on the new pneumococcal vaccine, but they did it in the Netherlands, so they could only do it because Netherlands does not use any pneumococcal vaccines by their national health insurance. So no one there had the original one. So they did this study. It didn't show any real benefit. There were a couple few cases of pneumonia, but no reduction in hospitalization, no reduction in death, no reduction in severe pneumonia. And then they came out by recommending you get both vaccines. So I actually called the CDC back then and I talked to someone in their vaccine division. I said, you didn't study both vaccines together. They said, well, in the lab, it seems to work. I said, but the world's not the lab. Things completely change when they get out in the world. Well, this is our recommendation because we think it would be good. And I'm like, why didn't you study it in people with the original vaccine? Well, that's not how the study was done. But this is what we're up against, Alan. I
No,
mean,
so
no, nothing studied.
nothing studied. So let me talk a little bit about the pneumococcal because that's the one I honestly of these I've done the most research recently because I literally get a call from the ID doc at my hospital. uh, and wants me to remove the pneumococcal 20, which is what's called Prevnar 20, and change it to Capvaxive 21, a different manufacturer. And he was like very passionate about it. And I was like, all right, how many dinners does this guy go to, or is he on the speakers list for the drug company? So I did a deep dive, and number one, what people need to understand, as Andy said, this only is about pneumococcal pneumonia. And when they're talking about the different numbers, it's the strains. And there's literally hundreds of strains. And just like with the flu, that the flu vaccine changes every year, in the pneumonia vaccine, the strains are different in different parts of the country, in different age groups. So the reason I did the research was one, that call, and two, he said, you got to put it into the faculty practices as well as the clinics. So I went and looked at the costs of the vaccines. Number one, there is no recommendation of if you got one of these or one of these. Like there's literally four out there. It went from pneumococcal to Prevnar 7 to Prevnar 13 to Prevnar 20. Now it's we add this Capvaxive vaccine. There's no guideline from anywhere. Like if you got this one and this one, should you get this one? And what Andy said is the most true. So I did one of the deepest dives in the literature I could get. I got every article that's been produced, and there is no real article out there. Zero. There is zero evidence that this vaccine is cost effective in any way. So the cost of the vaccine to a practice, I call it a practice like CVS Minute Clinic, where they buy literally 3 billion of them, they get the cheapest rate. Hospitals who give Medicaid get the cheapest rate. Small practices, small private practices, small faculty practices have to pay the highest wholesale rate and often lose money by giving vaccines to their patients. So I often tell the patients, if you really think you want this, go to the pharmacy and get it, because otherwise we have to stock like, hundreds of thousands of dollars worth of vaccine in your fridge and freezer. But the ultimate end game was there is no real study, and there are like machine learning type of data, experiential learning that says like if everybody got vaccinated, you could save 1,000 or two lives. You could, but there's no evidence of that.
Yeah, and that's a big leap to say you could save any lives, to be perfectly honest. And we don't know. And I said this to the CDC guy when I talked to him. And I said, we don't know if you cover more strains, whether the actual coverage for each individual strain will be less. I said, we just don't know how combining these things together. My own experience, Alan, from another CDC misaligned statement that I asked them about, was that over the last 2 years they wanted older people to get all these vaccines at the same time. So you get flu, COVID. They even came in with shingles, the new Pneumovax, and RSV. They came in with all these vaccines. I was shocked to see how much they cost.
Yeah, and the thing is with that, just sorry to interrupt. The thing is, they have not studied the vaccines together, but they say there's no evidence that it's a problem. It's
That's
like,
exactly what they said. They said, we have never studied these together. But that doesn't matter because our expert panel believes that this is okay. I said, well, wouldn't you want to study them together in older people? Because here's the deal, and Alan and I know this, older people have crappy immune systems. And honestly, think about the flu shot, which we've been giving for a long time. When you come in for a flu shot, they say, have you had a cold recently? Are you sick? Do you have a fever? Why? Because if you're sick and you get this flu shot, you're not going to make immunity to the flu because your immune system's too busy taking care of the cold you have right now. That's an older immune system. It's not very robust. So you give all these vaccines at the same time. These people don't have an immune system. That is common sense. They can't make antibody. And the COVID shot, which is an mRNA shot, stays in the system for months. So anything you get after that, forget about. You're not going to make immunity to it. What I saw, Alan, I wish I was a scientist instead of a doctor. Um, what I saw in all the long-term care facilities that did not listen to me. And what I said is split the shots. Flu first, COVID 2 weeks later. If you want to get RSV, and again, there's very little data on RSV, get it after those two. The
yeah,
place, the place that listened to me did not get any influenza the last 2 years. The places that got the shots all at once, got tons of influenza in their facilities. You don't have to be a physicist to realize why that's the case.
Absolutely. And again, the only way to really study this stuff is to do immunity testing on people for each shot they got after they got one or two or three or seven. And I guarantee you'll see the differences, but they're not going to study that. We have the ability to study it. They're not going to study it because pharmaceuticals don't want to put in money to prove themselves wrong in a study. They're just not going to do it. And last year, I actually hospitalized one patient who went to one of the pharmacies again and did what I said, as I agree with Andy 100%. I never give more than one vaccination at a time unless there's absolutely no choice for some medical reason, or sometimes it's travel and people want it. And I still say they're nuts for doing it, but they do it. And I had a lady go to the local pharmacy, get the pneumonia shot, the flu shot at the same time. Again, never really studied. Came to me with 104 fever. I had no idea what was going on. She looked like crap. I had to put her in the hospital.
And this is what we're seeing. We're seeing people, everyone in my facilities who has COVID now and flu now have gotten the shots, and they got them together, and it's really insane that we can make it, and it's not just when the CDC makes a policy like this, they're adamant about it, and the doctors just listen and just do, and I'm like, where's the evidence? And I was a little pissed during COVID about many things, but one thing was our country decided it wasn't going to study anything. It didn't study any aspect of the declarations it was spitting out about what we're supposed to do. There were studies done in other countries, and that's what we often had to rely on. But why didn't we decide, okay, let's study this vaccine? Maybe for the kids, it's not a great vaccine. Maybe in adults, maybe in very old people, we have to use a different dose. Let's figure it out. We have all this time, but they didn't. They just kept making boosters. And you're right, if they study it and it has a negative result, that's going to hurt their bottom line because right now doctors are just doing what they're told. And by the way, it's not doctors this time. You go to a pharmacy to pick up your drug and they start pushing vaccines on you. They'll give you four vaccines at that moment if you say so. A funny story, Alan. I was in a long-term care facility when the pharmacy was in there giving vaccines, and I was doing my notes in the back, and some lady comes in and the pharmacist says, "So do you want your insurance will cover the RSV and COVID and flu all." It turns out the RSV is like $800 if
Yep.
it's not covered. But um, she said, "Well, my doctor said I shouldn't get all three at once." And the pharmacist said, "Well, your doctor doesn't know what he's talking about because the CDC says you can. So it's perfectly safe. I'm rest assured." So I walked out. I was the doctor.
It's, and this is what people are being told. It's such hubbubaloo. And the other thing is, we talk about everything in medicine now. Every article you read about shared decision making and patient centered, and we shouldn't be forcing things on people. We should have a conversation. What is their risk of getting something? What is their benefits of getting the vaccine? So I really do that, especially with the shingles vaccine, which is one of the biggest thorns in my side for a lot of reasons. But I actually gave it to one of my patients in the past and I honestly killed them. So, I'll go through that. So, for the folks that, don't quite understand, all viral vaccines, which, the big ones we give are flu and the shingles and the RSV, what Andy just talked about, the respiratory syncytial vaccine. All of those antiviral vaccines have a small incidence, but not unheard of incidents of something called Guillain-Barré syndrome. And if you haven't heard of Guillain-Barré syndrome, it's a demyelinating kind of autoimmune response that happens to the body's immune system that goes crazy after getting the virus or getting a vaccine. Okay. And if you get it, it could be a killer. So there is a small incidence, and I've done this research as well. The vaccines increase the incidence of Guillain-Barré by 3 to 6 times the amount of people who are getting this vaccine. And we're talking about several, like 6, 10 people in a million. Think about how many people are going to the pharmacy today and getting vaccines. People are getting Guillain-Barré. Guillain-Barré has a 5 to 10% mortality rate and another 25% rate of making you totally disabled. And one of my patients died after getting it. But the real thorn in my side is 90%. I'm sure I'm wrong. I'm sure it's 99% of people that get shingles, the painful rash that takes over your body and eats your face away by the commercial. 99% get an itchy and sometimes painful rash that lasts 1 week and it goes away and they don't have another problem. It's the people who are immunosuppressed, whether they're getting chemotherapy for cancer or they have lupus or some autoimmune disease, because we know it's a screw up in the autoimmune system that makes people get such horrible shingles to begin with. So we're taking people with no risk and giving them something that could kill them. And now when patients ask, and then they say to me, "Did you get the shingles vaccine?" And I say, "Well, no." And why? I tell them. I tell them. I don't hide it anymore.
Yeah, and that is exactly what shared decision making is the idea that there's no right answer and there's no free ride for any of this stuff. Every intervention we make as doctors carries with it both risks and benefits, and each person has a different risk and benefit than the next person. So, like you say, Alan, if someone's immunocompromised, they might have a more of a benefit profile to getting this vaccine. I have been quite in the last 25 years of my practice, because when people get shingles, we often give them a virus, an antiviral medicine that does quiet it down. It works in this case, unlike Paxlovid. I haven't seen this post-herpetic neuralgia in the last 25 years because people either have very limited cases or we give them this antiviral and they don't get post-herpetic neuralgia. So that's the main thing with the shingles vaccine to protect. And I actually did have a patient who developed after the vaccine a very atypical form of shingles where they had knives going into their body all over the place. And by the way, this never went away, and they ended up dying
Yeah.
of a cerebral
That's
hemorrhage from
disseminated
stress.
shingles. It's
Yeah, and
known
that's what the
disseminated.
shot gave her. So ironically, the family, like years later, I heard a rumor that they thought I killed her because I refused to give her the vaccine. Because if she had had the vaccine, this wouldn't have happened. This is the irony because she actually got the vaccine, and that's what caused it. But
So
rare, but
I
happened.
I've had two patients in my 40 years of practice with post-herpetic neuralgia. One was got herpes, the shingles when she was hospitalized getting chemotherapy.
Okay.
And that's when she got it. And the other lady, it's a bad case. She's still in my practice now. She does have severe pain. She had, or she has rheumatoid arthritis severely and is on several immunomodulating biologic agents for it. And that's the patient that could be a setup. And this patient had the shingles vaccine.
Oh, they had it. Well, there you go. Yeah, and that's the other problem. The people who would benefit the most from it, the immunocompromised, don't necessarily make immunity when you give them a vaccine. So
Exactly.
it's like the old people too. They don't necessarily make
Well,
immunity.
if you give someone a vaccine and they're on 40 milligrams of prednisone, the
Yeah,
prednisone is suppressing the immune system. How do you expect them to develop it? You know?
exactly. It's a great irony. The people who need it the most don't often benefit from it. Yeah, and just jumping a little bit to Tamiflu and Paxlovid. These are medicines that are being marketed as if you get a flu, you take Tamiflu. If you get COVID, take Paxlovid. It rhymes, so it's kind of nice.
Yeah.
But it is there are no articles that support their use. Tamiflu, there's a whole story that's in our book about how the CDC actually was bought off by pharmaceutical companies to create reports and to bury studies that proved it didn't work. And it was Cochrane over in Europe that revealed all this, and they pulled out the unpublished studies. They showed it didn't work, and the CDC refused to look at them. And so to this day, if you get flu, you get Tamiflu. You go to urgent care, Tamiflu. I'm required to give it on long-term care if even two people have flu, even though we know it could get older people sick. Paxlovid, every study has shown no benefit. I argued with an infectious disease doctor early on because there was this crazy Israeli study that was observational that he relied on. But yeah, just this week in the New England Journal, two new studies came out that show Paxlovid clearly doesn't work. But Alan, 2000, I looked this up, 2024, $5 billion of sales. 2025, $2.5 billion of sales on Paxlovid. And by the way, COVID in 2025, it was a cold. It was not a bad illness.
Still a
But yet
cold.
they're giving out a medicine that doesn't work for a cold. And it's just this programming, right? I don't know if it was the TV commercials or the idea that everyone said you should be on this, but look at the data. It
Well,
doesn't
we
work.
we used fear in this country. COVID, fear was used. That's why people rushed and got the vaccine. I unfortunately got two of them because I couldn't go to work and I still need to feed my family and have a kid in medical school and I have bills to pay. And knew it was a mandate in New York. If I didn't get the vaccine, I couldn't work in the hospital. So I got the first two. And I am convinced that it is the second shot that I got literally 4 weeks after COVID that just screwed up my immune system and gave me long COVID. I have a couple of long COVID symptoms. I have body aches all the time. I'm tired all the time. And and I can't name things. It doesn't come to my
There
head.
you go.
People say, it's the stress you went over. We'll talk about it, but I ran a COVID ward for almost 8 months in my hospital. It wasn't that. I grew up in the AIDS epidemic. I dealt with the same thing back then where every patient in front of me died. Every patient died. And I worked in an inner city hospital. I worked at Coney Island Hospital at the time. Everybody had AIDS and everybody was dying. And it wasn't PTSD and it wasn't anything else. It was just getting that vaccine to me a few weeks after I had COVID, when my body was already trying to build some immunity, it just screwed me up.
Yeah, and it was the mandate also, I had a good friend who came and said, "Look, I had bad COVID. I have very high titers. Look at the
The
titers. Why do I
titers.
need a vaccine?" They
Yeah,
said,
that
"Well,
was funny too.
you still need it." You
Everybody was
still-
asking for titers.
Yeah, everyone wanted titers, but this guy had like off the wall, and it was and he says, "Why do I still need a vaccine when I clearly have made my natural immunity?" And they said it's a requirement. There was no thinking involved,
No.
and that's often the case with vaccines because it's become political. Either you're pro or anti-vaccine, and just from us having this conversation, we will be deemed
Yeah.
anti-vaccine even though
And
we give them.
and getting back to Paxlovid, you know, th- if people want to extrapolate it and give this drug to people who, COVID was likely to kill and you're giving them something, at least you could say scientifically, I'm taking a long shot or something like that. But to give it to young, healthy people, and like Andy said, the commercials say, if you have Paxlovid, get if you have COVID, get Paxlovid. And the early data clearly showed it should only be given to very high risk people who they're going to die and give them something. But we know that besides the fact that it didn't work, and it's now been proven that it didn't work, number one, people will continue to prescribe it because they want to say they're doing something for it. So people still come into the office. But about half the people stop it for the GI side effects that they can't tolerate it. And another third of people get what's called rebound COVID. So they get better, and then like 2 weeks later, they get COVID again, but worse this time. It's just utterly ridiculous.
And again, ironically, I remember both President Biden and Anthony Fauci got rebound COVID from it, but they still kept endorsing it, even though they kept getting COVID over and over and over again. And it has a lot of drug interactions, and so older people who are on medicines, they could literally kill you. So it's not a safe drug and it doesn't work, but let's keep prescribing it
Yeah.
for a cold. So it just everything just makes complete sense.
Well, they have good commercials. That's a reason to
Have good
prescribe it.
commercials. It just shows you what the data just gets trumped by commercials every time. So data is meaningless. The fact that two articles in the New England Journal, which is by the way a heavily pharmaceutically advertised journal, that they don't like it should close the door on this drug. And I guarantee you, I'll check the sales in 2026. They're going to be up in the billions. I guarantee you. That's
Because 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 the doctors don't have common sense.
no.
You know, I don't even know what to say. We give things to people like, some of the other vaccines, which we haven't had a chance to discuss yet, like that. I have patients coming from the pharmacy, adults, and like they've been given hepatitis A and B. And I'm like, what? Like, why did
What's
they
the
give that
risk?
to you? Uh,
Right.
you know, uh, hepatitis B is from, blood and body fluids. So, sexual contact, IV drug abuse, and they're giving it to these 70-year-old people who probably haven't having sex anymore and are certainly not shooting drugs. Like, half of them probably have immunity anyway. It's just unbelievable because we vaccinated our children. I was vaccinated for hepatitis B, so it's again, another mandate for working in the hospital. And it happened to my son. My son's a non-converter. So I had to give him two shots, two series of hepatitis V vaccines. And when you go and work in a hospital or a nursing home, they want to see your titers. And if your titers are not there, they make you get more vaccines.
Oh, jeez. It is, that's the point. The point is not, it's not a pro anti-vaccine stance. Point is we should be doing more research on these things. And we should give patients choice. And we have to realize we don't know a lot. We just don't know whether a combination of vaccines is dangerous or ineffective or how you should give them or whether which patients benefit the most. It's almost like over 65, you have to get this vaccine, but over 65, people over 65 are a heterogeneous group of people. So some might benefit, some may not.
And our oath is do no harm. So if there's two choices to make, give something that we don't know for sure is going to help, or don't give it because they'll probably be fine. Well, don't give it, so they'll probably be fine. And that is really the way you should practice medicine, in my opinion, until something's proven. And then when something gets proven, like, let's see how much airtime. I haven't seen any, eyewitness news reports on, hey, the Paxlovid doesn't work at all. New England Journal of Medicine, considered one of the most respected journals in the world, if not the respected journal, along with Lancet and BMJ and JAMA and stuff. Those are considered the top few. And here it is. This article is saying drug doesn't work. I guarantee you, people who are reading the article are still prescribing it. But the thing is, most doctors don't read the New England Journal, don't see that it doesn't work, and continue to prescribe it. And the commercials are not going to stop after this study has come out. You're going to still see, if you have COVID, get Paxlovid.
Exactly. And that doctors will listen to the commercial. So anyway, so we'll spend more time on COVID because it really was um tough. And for the whole country and for us in particular. But okay, so
And I
Alan,
do know for a fact that when Andy had 5 minutes when he wasn't caring for patients, he was doing COVID research. So I know that for a fact because he could give
I
you
was,
every
yeah.
number. But yeah, I just want to say one thing before I start about both of our state medical boards. Me and Andy are not anti-vaxxers. We believe in appropriate use of vaccinations for the appropriate people after a shared patient-centered decision-making conversation. Have a great week, everybody.
Take care. And we do give out a lot of vaccines.